Okay. Good morning. Welcome to the first PSI Research Symposium since the pandemic started. I think our last was 3 years ago, if I recall correctly. And maybe some of you were in attendance at that time. It is certainly a joy to see everyone here in person and to be able to resume some of our activities in a non-virtual setting. We have what I think will be an exciting day of presentations, and we also will have some time for discussions and descriptions of PSI activities, and an opportunity for you to have some table discussions and provide some input to PSI as well. We found the input we got at that last research symposium 3 years ago tremendously helpful in planning activities from PSI and attempting to serve our grantees better. I will note that this event is an accredited group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada and approved by the Continuing Education and Professional Development Office at the Northern Ontario School of Medicine. And I think I'm forgetting to advance the slides. So I want to move first to begin by acknowledging the land where we find ourselves. We acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississauga of the Credit. So this morning's schedule is on the screen. It's also printed out, and you'll find copies at every table. After these opening remarks, we have two presenters this morning, who are Dr. P.J. Devereaux and Dr. Deborah Cook. We are hoping that Dr. Cook does make it here because she was on her way from Hamilton and called to say that progress was slow. And those of you who live near here will be very familiar with the wonders of the QEW on a weekday morning. Those presentations will be followed by a PSI resident presentation session, and we always tremendously enjoy hearing those. Following those presentations, we will be serving a catered lunch made up for us by the Sheraton staff, and I'm sure you'll enjoy that. After lunch, we're going to start with a little fun, a short Kahoot quiz, which will be hosted by Dr. Andrew Gershon and Mr. Samuel Moore. Dr. Gershon is a member of our board and of our grants committee, and Sam is our executive director. And they're going to test your PSI knowledge, and there will be a prize for the winner. And I do not know what that prize is, but I will not be participating in the quiz. Some people might consider that a slight conflict of interest. Following that, we will have a COVID update, a roundtable panel, and open floor discussions. And then our final presenter of the day will be Dr. John Marshall. After that, following closing remarks, which I promise you will be extremely brief, we will move to our evening cocktail reception. And that's why my remarks will be extremely brief. We published online, and you'll find the full report on our website, something called the Impact Report. And this describes some of the activities of the PSI Foundation. In there, I have included some remarks, and I'll just summarize a couple of the points. Some of this we will be talking about at greater length later. The first thing, obviously, is to state the obvious that the global COVID-19 pandemic has disrupted the whole world. And that includes medical activity, it includes healthcare, it includes clinical research. We responded with a COVID-19 funding stream within weeks of the start of the pandemic. We got a huge response. We got over 100 applications, and we were able to fund over $1 million of projects to do research right at the beginning of the pandemic. Last year, we also increased our funding for salary support for grants through the PSI Graham Farquharson Knowledge Translation Fellowship Award. Sadly, we lost Graham Farquharson just a few months ago, but this KT Fellowship Award is named in his honor. And that funded 5 early and mid-career investigators. We also supported 6 research trainees in their work towards a research career. And of course, all of this is on top of our usual funding streams for operating grants, new investigators, and so on. We now have 11 funding streams that support physician-led research across the province. Meanwhile, our staff, our volunteers, and our communities adapted virtually to keep the grants flowing, even though they too, of course, were suffering the effects of the pandemic. And we're certainly extremely appreciative of both our staff's work to keep things going and of the work our volunteers do through committees and the board. So we continue to strive towards fulfilling our mission of improving the health of Ontarians through the support of physician-led research and education, and will continue to do so in the years to come, whether or not we suffer any more pandemics. Monkeypox, anyone? Probably not. So we also would like to remind you to fill out the symposium evaluation during the event. This provides us with tremendous feedback. It's also, of course, a requirement for CME accredited events. We'd appreciate your feedback, and after each presenter, the QR code on the screen is accessible through the link you see there as well, if you aren't able to scan it. And we will, of course, provide these after the symposium as well, and put it up during breaks so that it's easier for you to do your evaluation. So keep your eyes out for them. So thank you for being here. Thank you for your time and attending this symposium. I will just mention, if you're tech savvy or social media friendly and you use Twitter, you can tweet about today's event with the hashtag PSI Symposium 2022. So it's now time for our first presentation, and I'm going to hand over the podium to our board member and grants committee member, Dr. Andrea Gershon, to introduce our first speaker.
Hi, so I have the honor of introducing our first speaker, and I just want to say it's just so nice to be back in person, so thank you all for coming. Our first speaker, I'm a big fan. Had a chance to meet him during the pandemic and hear about his work. Dr. P.J. Devereaux is a cardiologist and has a PhD in clinical epidemiology. He is the director of the Division of Perioperative Care and Cardiology at McMaster University. He is the Associate Deputy Director of the Population Health Research Institute, as well as the scientific leader of the Anesthesiology, Perioperative Medicine, and Surgical Research Group at the Population Health Research Institute. Dr. Devereaux is a full professor and a university scholar at McMaster University. Dr. Devereaux's clinical research focuses on the vascular complications around the time of surgery. He is undertaking several large international RCTs and observational studies addressing this issue. He has published over 250 peer-reviewed papers and 50 book chapters and editorials. He is supported by a Tier 1 Canadian Research Chair in Perioperative Medicine, and he holds the Yusuf Chair in Cardiology at McMaster University. And Dr. Devereaux was funded by PSI, can I say? In 2010 for their neurovision pilot study, and as a co-PI in 2013 for the hip attack trial. Please welcome Dr. Devereaux.
So thank you very much for the opportunity to present here today, and I agree that obviously it's very nice to finally start seeing people again, and hopefully this will be the switch where we'll all move in this direction. So I just want to start off by saying research only happens because of many people. It rarely happens because of single individuals. And certainly research that actually impacts and changes things happens because of a large collection of people. And I'm enormously grateful to PSI for their support over many years, which played a huge role in helping fund our research program. Of all the studies I will present today, we receive PSI funding, usually for the pilot work or vanguard phase of these studies. And one thing I want you to know is that we use your money well. We leverage it over 200-fold. So a lot of times, it's real money that PSI is giving, or maybe $50,000 or $100,000. For the real studies we pull off, often is in the range of $10 million. And without that first step, you don't get to the second step. So we're just very appreciative of what you've done. This is my disclosure as part of our university policy. So I'm a member of a group which has a policy of not accepting direct payments for our own personal financial gain from industry. We will, however, take as much money as we can possibly get from industry and undertake research endeavors. And based on questions I've originated and ideas that I've come up with, I've received grants from many different companies. So the goals of the presentation today is that I'm going to first give you insights into the magnitude of the problem of complications in the surgical setting. One thing I really want to make clear up front is that our research focuses on complications that happen perioperatively. We should never lose sight of the fact people have surgery for very important reasons. And by focusing on complications, our goal is to figure out how we're actually going to predict, prevent, identify, and better manage so that anyone, regardless of age or comorbidity, can safely receive surgery at any time. So just please keep that in context that although I'm focusing on the complications, we should never lose sight of people are having this for a very important reason. I'm going to talk to you a bit about our perioperative aspirin work. Then I'll get into the issue about perioperative covert silent strokes. And then I will talk about the potential for colchicine in the perioperative setting and its relationship that may be relevant to preventing atrial fibrillation and myocardial injury after non-cardiac surgery. And then I will talk about the timing of surgery, which there's many things that's, we can affect people's age, but there are modifiable things that many people thought we couldn't do, but actually varying the time of surgery for urgent emergent surgery is something we actually can control, and it's something that actually may be modifiable in terms of improving outcomes. And then I'll finally give you some insights into chronic incisional pain and some of our work on that. So first, for the magnitude of the problem. So globally, there's over 230 million adults worldwide who undergo major surgery on an annual basis. So it's very large. It is continually growing throughout the last 40 years. It differentially grows in the elderly and people with lots of comorbidity. The VISION study was a large international prospective cohort study of 40,000 patients that we undertook. And we undertook this in 14 countries with 28 centers. We had over 70 funding sources. We wrote a lot of grants to actually pull this study off, and it informed a lot of things in our research program. A really interesting thing that it did inform is just people's perceptions about complications and also what periods really matter. And sometimes we are focused on one thing and missing the point that the data is saying a problem exists somewhere else. Most people's vision of surgery is that they're typically anxiously waiting in a recovery room for the surgeon to show up and tell them their loved ones survive. But the reality is the OR is the safest period of the surgical process. The real point is the patient's family should show up the next day and say, are they alive? It's not during the OR. Now, that doesn't make sense because surgery should be the highest risk period. In the past, 100 years ago, it was the highest risk period. 100 years ago, we only did surgery on young people with very little comorbidity. Today, we mainly do surgery on older people with lots of comorbidity, yet intraoperative death has plummeted. And there's an important message about why that likely is happening, and it's actually been something that's actually been very relevant to our research program. So in VISION, we demonstrated of the people that would die during the first 30 days after surgery, less than 1% of them would die in the OR. Almost no one dies in an OR. 70% of them that were going to die would die in the hospital after their surgery, and almost a third of them would die after being discharged home. And no one is sent home to die. People obviously have had either complications, may not have been recognized, or had a complication after going home, and then some of them would succumb to that. And again, this offers potential, if we were been able to plummet intraoperative death, that we actually may have the potential to plummet postoperative death and improve outcomes. Another big thing that exists is that it's a huge stress on our overall system. If you take anyone age 45 or greater having non-cardiac surgery, 7% of those patients are going to be readmitted to the hospital within a 30-day period. That is an enormous number of patients. And if you start getting to older age populations, it rises a lot, or if you get into urgent emergent surgery, it's much, much higher. That is an enormous stress on the actual system, and again, huge potential for us to improve that. This shows you from VISION the major complications that happen after non-cardiac surgery and their relationship to 30-day mortality. So the first column shows you the complication. The second one shows you the percentage of deaths that occur in the patients who have that complication. And the next one is the adjusted hazard ratio, and the last one is the attributable fraction. The attributable fraction I would advocate is probably the most important statistic on the slide, because you may have a risk factor where if you have this risk factor, you are going to die. But the reality is, at a societal level, it explains very little death because 1 in a million people have that risk factor. So when we want to understand an impact of something, we want to understand its strength of association to death, but actually how many people have that complication. And those two things inform whether or not you have an attributable fraction and how much of the deaths may be accounted for by that. And what you'll see is that most people think that venous thromboembolism is the most common way to die after surgery. It is important and it can kill you, but in fact it accounts for very few deaths in today's world, likely driven by 2 points. Number one is that people are mobilized much faster than 40 years ago when they had surgery, and surgeries become less invasive, and most people get VT prophylaxis. But in today's world, 3 things actually are dominant players to death. They include myocardial injury after non-cardiac surgery, bleeding, and sepsis infection. And if we really want to tackle mortality in the next 10 years after surgery, that's where our focus should be, because that's what accounts for the majority of deaths that are happening. Perioperative covert stroke. The first big trial that our group did was called the POISE-1 trial, and it was looking at beta blockers in patients having non-cardiac surgery. And in this trial, we demonstrated that beta blockers were clearly beneficial. They prevented myocardial infarction, but they increased the risk of stroke and they increased the risk of death. The strokes were incredibly devastating strokes. So of the patients who would have a stroke in the perioperative setting, a third are dead within 30 days. Of those who survive, over 55% are incapacitated or needing help with everyday activity. These strokes look much worse than strokes out in the community. Now, we had already undertaken work to demonstrate that the majority of people that will get myocardial infarction, so heart attacks or myocardial injury after non-cardiac surgery, will not have ischemic symptoms. Most of the events happen in the first 24 hours after surgery, when people are typically getting narcotics that are very good at masking ischemic pain. People don't recognize it. We did a lot of work to uncover that whole area, but it also made me wonder, if we're seeing all these really devastating strokes, is it possible there's other strokes that are happening similar to the myocardial injury story, but because of all the confusion that happens in the postoperative setting, may not be recognized, but may actually also have prognostic relevance. So based upon that, we undertook the neurovision study. Again, PSI funded the pilot for this. This is Dr. Marco Bratta. He was doing his MSc with me. He's in London, Ontario, and he led both the pilot and the full study with me. So in Neurovision 1, we included just over 1,100 patients, and these patients were age 65 or greater and undergoing elective surgery. So this all had to be elective surgery, and it was a representative sample. We ended up having 12 centers in 9 countries that participated, and all these patients, we did a brain MRI on them between day 2 and 9 after surgery. And because we used diffusion-weighted imaging, if you see a stroke, you know what happened in the last 10 days. So we don't need a preoperative brain MRI. We only need a postoperative brain MRI. And postoperative brain MRIs are expensive enough. We were trying to really prevent the need for one before surgery. We demonstrated that 7% of patients, consistent across all centers, consistent across all forms of non-cardiac surgery, had a new covert stroke on their brain MRI after their surgery. So again, this is not recognized clinically, but it exists on your brain MRI. So in the upper pictures here, you're seeing patients, you'll see little white lucent areas where these are covert strokes, and the bottom panel is a single patient who has multiple new covert strokes in this setting. So 13% of people that would have a new covert stroke had multiple covert strokes. We then wanted to understand, it's one thing to say we've identified a phenomena happening. The issue is it actually prognostically relevant? Should we care about this? So our interest was on the issue of cognitive decline as the major focus. And what we demonstrated was, at 1 year after non-cardiac surgery, 29% of patients who did not have a perioperative covert stroke had cognitive decline based upon a drop of 2 or more in your MoCA score, which should not be happening to you within a 1 year period. 42% of people that had a covert stroke had cognitive decline at 1 year. And then when you do a risk-adjusted model where you account for age and other predictors of cognitive decline in the coming year, we see that basically getting a covert stroke after surgery doubles your risk that you're going to have cognitive decline in the coming year. We also looked at the issue of delirium, and we demonstrated that the patients who get postoperative covert strokes had over a 2-fold increase in the probability they would get delirium in the first few days after their surgery. And we also demonstrated that in the coming year, after patients had their surgery, there would be a 4-fold increase in the probability the patient would go on to have an overt stroke or a TIA if they had a covert stroke after surgery, which again holds out hope that this is going to be modifiable. Because if more events are about to come and we can identify those events, then that gives us opportunities to intervene to change that trajectory for these patients. This is Dr. Maura Marcucci, who's leading the Neurovision 2 study with me. And in this study, what we're doing is we're having patients wear continuous monitors which can measure like 12 biophysical parameters, and one of them being continuous 5-lead ECG, blood pressure, heart rate, heart rhythm. And we're looking to see how often atrial fibrillation may be related to these perioperative covert strokes that are happening, and also a whole lot of hemodynamic issues. The effects of perioperative aspirin. So PSI was kind enough to fund the POISE-2 pilot study, and we wanted to test the question about perioperative aspirin. Now, it was a very interesting experience trying to do the POISE-2 trial. There was places in the world and centers that would absolutely refuse to participate because it was so clear that aspirin worked and you had to give it to patients having non-cardiac surgery. And there were centers in the world that refused to participate because it was so clear that aspirin was dangerous and you should never give it to patients having surgery. So we ended up doing this trial. We randomized 10,000 patients. And basically, the aspirin trial was 2 trials in 1. So about half of the patients were on chronic aspirin. They had to stop aspirin at least 3 days before surgery. On average, they stopped at 5 days before surgery. The day of surgery, they were randomized to resume aspirin or get placebo. And then roughly half the patients were people that were naive to aspirin, and on the day of surgery were randomized to get aspirin or get placebo. And what we demonstrated is that there was no impact on cardiovascular death or myocardial infarction by giving aspirin during the perioperative setting. However, in fact, there was an unequivocal increased risk in major and life-threatening bleeding in these patients. And so even though most people have thought aspirin is benign, there is no apparent benefit that we're getting from aspirin from a cardiovascular side of things, but there was an unequivocal harm. As in a lot of stories, I can't remember what I skipped past, but anyways, there was a sub-study that we did because There's a lot of data on patients who have coronary artery stents that they are very vulnerable in pro-inflammatory states. They can get in-stent thrombosis. And so we undertook a sub-study within POISE-2 where we looked specifically at the patients who were coming to surgery that had an underlying coronary artery stent to see whether or not aspirin was beneficial in that group. In that group, unequivocally, we saw a benefit. So we saw a very substantial reduction in the risk of patients having cardiovascular death or myocardial infarction driven by myocardial infarction if they, in fact, got aspirin during the perioperative setting. And so, again, this highlights that there may be one effect in an overall population, but sometimes there are very important subgroups that actually matter. And so in general, continuing aspirin in patients having non-cardiac surgery is going to increase risk of bleeding without apparent benefit, with an exception being patients who have underlying coronary artery stents. This is Michelle Graham, who was the one who led us in the sub-study on POISE-2. And Michelle's a cardiologist, interventional cardiologist in Edmonton. Perioperative AFib. So this shows the histology of a patient who has lone atrial fibrillation. So we're not sure why they have atrial fibrillation, it's typically at a younger age, and we see that they have a lot of inflammatory cells in their left atrium. And this shows you the inflammatory scores in patients who get atrial fibrillation, and the higher your inflammatory score, the higher the probability it is that you will in fact develop atrial fibrillation. And if we look at inflammation in the perioperative setting, obviously, understandably, we're doing a traumatic insult, and a lot of inflammation happens in the surgical setting. And there has been RCTs looking at colchicine in patients undergoing cardiac surgery. Smaller trials, but certainly look very encouraging for prevention of atrial fibrillation in patients undergoing cardiac surgery. This is Dr. Amal Bessissow, who was doing a master's with me at the time. She's now at McGill University, and we undertook a pilot study that was funded by PHRI to look to see in patients having thoracic surgery if we gave colchicine. This was a first established feasibility, but our real goal was to understand, could we prevent perioperative atrial fibrillation in this non-cardiac surgery setting? And also we were interested in the issue of myocardial injury, and also a lot of patients have chest tubes for long durations of time after thoracic surgery. Could we dampen down what is believed to be a driving factor of the inflammation, and actually get chest tubes out sooner? So in the pilot, we randomized just over 100 patients, and we followed people for 30 days. We demonstrated that the study was feasible. And we had an encouraging signal around the issue of perioperative atrial fibrillation was in the right direction. And even for the duration of time of the chest tubes, it was statistically significant, reducing the chest tube time, people that were getting colchicine. Now, I offer tons of caution. It's 100 patients, and I don't believe trials that are small, but certainly it was encouraging data. And this is Dr. David Conen, who we were fortunate to recruit from Switzerland, who's come and worked in our group. And David is leading us now in the full COP-AF trial, where we're randomizing just 3,200 patients undergoing thoracic surgery to either get colchicine or placebo for the first few days post-surgery. We're about 2,500 patients into this, and we should finish the trial by the end of the year, and we'll have an answer to this. And we have two co-primary endpoints. Can we prevent perioperative atrial fibrillation? And the second one is, can we prevent myocardial injury after non-cardiac surgery? Some of you may be aware that in cardiology broadly, we are now commonly using colchicine, especially in people having acute heart attacks, and there's a lot of large trials showing very beneficial data to actually prevent recurrent heart attacks and vascular events. The timing of surgery. So this is the hip attack 1 trial. So about 10 years ago, I was on call for cardiology, and I got a call from an anesthesiologist who says that there's a 70-year-old woman who's in Emerge who had presented earlier in the day, had fallen, fractured her hip. It was early July, and someone did a troponin. The troponin was pretty significantly elevated. The patient didn't have any chest discomfort. The resident who was new and on had read that hip fractures often bleed. Pressure was a bit soft, gave a lot of fluid. And when the anesthetist phoned me, they said, look, this patient has troponin elevation, some ECG changes, is clearly now in some heart failure, and you got to fix the heart before we're going to fix this hip. And like most physicians, I knew nothing about the timing of hip fracture surgery, the observational data at the time. And I think most of us infer information from patients that we've seen in one setting into another setting, often with caution, but nonetheless, that's what we do in terms of clinical practice. And so we embarked on I took this patient CCU, diaries quickly, STs resolved, and I spoke to one of my interventional colleagues who was on with me that weekend, And on the Sunday, the patient went to the cath lab, seeing an LAD lesion, and as cardiologists, if we see a lesion, we blow it up. That's the approach, and patient gets intervened upon, and patient comes back to me on dual antiplatelet therapy. Patient ends up bleeding later that day, ends up dying, never makes it to the OR. Now, obviously, cognitive dissonance being what it is, I'd like to tell myself this patient had really bad protoplasm and was destined for a bad outcome. But if I want to be honest with myself, the reality is I chose a treatment path with the best of intentions, but the reality is it resulted in the patient's demise. So based upon this, I really wondered if this current approach that we have, a sort of medical optimization of patients who are presenting with surgical conditions prior to their surgery, is really the right approach. And I spoke to Dr. Moa Banderi, who he and I had trained together. He's an orthopedic surgeon, does a lot of big trials, and Moa then said, well, there's all this observational data suggesting the timing of surgery with hip fractures is relevant to the outcomes. We then did a systematic review. We then did a pilot study, again, supported by PSI, and then we went on to a full study that tested this. And so we randomized just under 3,000 patients who were age 45 or greater who had a hip fracture. We randomized them to a process whereby they had to be in an OR if they were in the accelerated care group within 6 hours of the diagnosis, or it was just normal timing of whenever surgery happened. Now, normal timing would end up being, in a global context, 24 hours, and we were able to achieve our 6-hour goal within our accelerated care group. Among the patients with accelerated surgery, we demonstrated that accelerated surgery didn't actually prevent mortality at a global level in this patient population. However, we did demonstrate unequivocally that there was overwhelming evidence that accelerated surgery substantially decreased delirium, and it was almost for certain that it drove it down through several pathways which were very clear. Number one, it decreased urinary tract infections, and it's biologically highly credible that's true, because as soon as patients start arriving at the hospital with a hip fracture, catheters go in, and the catheter's not coming out until after the surgery. And because in standard care, that surgery is happening almost 24 hours later compared to accelerated surgery, the catheter is just going to stay in longer, and it predisposes people to more UTIs. We also showed that we were able to decrease the issue of UTIs. We also demonstrated that we were able to decrease moderate to severe pain and several days in patients' post-operative setting. And we also demonstrated that we were able to mobilize patients much faster, weight bear, and actually left the hospital much sooner. So there were many upsides to it, but again, coming back to the original case that actually drove us to do Hip Attack 1, the subgroup of patients who had an elevated troponin when they presented to the hospital with their hip fracture, these patients have a devastating outcome. So mortality in the standard care group at 90 days is 24%. So if you show up with a hip fracture and an elevated troponin, about 1 in 5 of those patients will be dead in 90 days. But with accelerated surgery, 10% were dead. This result was highly statistically significant. It was an interaction. It was consistent with our biological thought because it was what drove the study to actually happen. And this is Dr. Flavia Borges, who is originally from Brazil, and she was doing a postdoc fellowship training with me. She's now, fortunately for us, she stayed on in our group, and she's now leading us in the Hip Attack 2 trial, which is testing specifically in patients who show up with elevated troponin and hip fracture. If we do accelerated surgery, can in fact we drive down mortality by decreasing the time that people are exposed to this very pro-inflammatory sympathetic driving state, which is often driving the myocardial injury. Finally, just the potential for lidocaine in patients having breast surgery for cancer. So breast cancer is the most common form of cancer that happens, obviously, in women. It's an incredibly common cancer. And when women have surgery for breast cancer, there's a very high probability that women will get very substantial problems with neuropathic pain, and it can have a very negative consequence in terms of their quality of life. There's a lot of reasons to think that lidocaine actually may be beneficial in this group, and so we were interested in studying to see whether or not if we gave lidocaine as an infusion around the time of breast cancer surgery, could we in fact drive down, by preventing sort of acute pain, intermediate pain, can we drive down the chronic incisional pain? So the planned pilot study, which was funded by PSI, we included, I think it was about 60 patients, and at the 3-month follow-up, we did see a statistically significant reduction in chronic incisional pain. Now I offer lots of caution, it's a small pilot study, but based upon that, we were able to leverage that to get funding through CIHR for the full study. And this is Dr. James Conen, who was doing his master's with me. He was at University of Toronto, he did his master's with me. He's an anesthesiologist. And James is now back at U of T, and he's the one who's leading our full plan study, and that's ongoing right now, and it's happening around the world. So in conclusion, perioperative complications are common. Importantly, again, it's important just to know about them and actually for us to figure out how we're going to prevent them, how we're going to better manage them so that, again, anyone can have surgery. Our programs inform the epidemiology, the prevention and management of these complications. Research only happens because of the support of many, and I just want to thank PSI for the support throughout the years that facilitated our research program. Thank you very much. Yes, absolutely.
I think maybe we have time for one question, if anybody has anything they want to ask Dr. Devereaux.
It needs to be a good one. Yes.
Hi, PJ. Thanks. That's excellent. Very impressive. I wonder why would they use marking instead of lidocaine for your post-op incisional pain?
Well, you're venturing now into territory of not my expertise. For certain, one of the things I've enjoyed the most about our part of research is that I get to work with also surgeons and anesthetists, and obviously they bring very different knowledge because of their background training. The anesthesia community and the pain specialist community certainly have had a lot of focus on lidocaine. There's a lot of encouraging data for it. But I say this point to people all the time that there's all kinds of stuff that we've studied and we've demonstrated, that certain drugs work in certain settings. That does not negate that other drugs won't work. It does not negate that another drug may even be better. But certainly there's very encouraging data around lidocaine. And the other thing too is that sometimes there may be a better drug and it'd be really worthwhile to study, but it's also you have to convince people to give you serious money to study these things. And sometimes because there's already background work on one drug, that's where you're more likely to be successful. But certainly the anesthesia community and the pain group felt that lidocaine was the one. I didn't get into this point. We also studied pregabalin in that study. It was a factorial. But pregabalin, which a lot of people use, actually showed no signs of benefit, and that's why we've moved to focus on lidocaine. I do apologize that I have to give a talk in Halifax for a cardiology meeting, but again, I just do want to emphasize that I know, physicians are giving money, and it could go to many causes, and those of us who are researchers are very appreciative of what you do, and I hope that everyone takes pride in what the Canadian community does in terms of research. Thanks.
Well, thank you very much, Dr. Devereaux. That was very, very interesting, even to a pediatrician. I come to think of it, I'm not sure if I introduced myself at the start of the symposium. I know I did for the annual general meeting, but maybe I'm anonymous to those of you who joined us after that. So I'm Robin Walker, the current PSI president, and I'm a professor of pediatrics at Western. We're now going to move to a short update on some PSI activities. And we're doing this through the day. We'll be hearing from researchers about their research, but we'll also try to give you a little bit more information about some of the things that PSI is doing. So this session will speak to two PSI committees, our Equity, Diversity, Inclusion Committee and our Governance Committee. The EDI Committee was just established last year, and we have the committee's chair, Ms. Giselle Bodkin, here to speak about its activities. Ms. Bodkin is an accountant with BDO Canada and joined PSI's Finance Committee in 2015, I think, and Board of Directors in 2020. Following that, the chair of our Governance Committee, Dr. John Drover, will provide an update on the recent activities of that committee. Dr. Drover is a professor of critical care medicine and surgery at Queen's University and joined PSI in 2015 as a member of both our Grants Committee and Board of Directors. So first, please welcome Giselle Bodkin.
Thanks, everyone. I'm sure it won't be as interesting as the last speaker. That was just amazing. I'm just going to give you an update of what we're doing around equity, inclusion, and diversity at our organization. So just starting with a quote that if you don't consciously include people, you may be unconsciously excluding them. So the why we want to look at ED&I in our organization is that our people, our stakeholders, our grantees, and are paying attention to EDI and asking questions and making sure that we as an organization are as inclusive as we could be and that there's no barriers. So our vision is to create an inclusive and equity environment where our grantees can fully participate in the PSI funding, and that PSI is being recognized as socially responsible for our nonprofit funders, universities, hospitals, academic, science, health centers. So our mission is to take a systematic approach by engaging more diverse grantees, supporting and funding diverse research topics, supporting and funding diverse geographical communities, having an inclusive and diverse board and committees, and fostering a culture of belonging. So we just got started. So we have kind of 3 areas we're looking at. One is our research funding, one is our grantees, and one is just our stakeholders, our structure, and our plan. So we've kind of just started with the middle. We have set up a committee, and we are organizing a plan for some activities. So the next 3 slides, some of the grantee projects that we're looking at, is updating our grant management system so our grantees can self-identify. I know a lot of people don't want to self-identify, but again, we cannot get any statistics on who we're supporting if people don't self-identify. So for instance, if we don't know how many women, we could have a gender situation where we're just funding one gender. So again, if there's any grantees in the room, it's really nice if people will self-identify, because that's how we can check our statistics. And we can maybe fill out some of our diversity grants, or diversity gaps. So on our research projects, we're just going to try and include EDI in our external funding and target EDI and ensure equitable diversity is being granted. So this is where we are. We have a committee, and we're trying to develop a plan with activities. We're just starting. Hopefully 5 years from now, things are moving along. So right now we have myself, Dr. Walker, Sam Mule, and I think Dr. Gershon is going to sit on our committee. So you'll hear back from us next year. Thank you for your time, and I think I'm passing it over to Dr. John Grover, who will talk about governance. Thanks. If you're next or not.
Morning, everyone. And point out some of Giselle's work has led to the first ever land acknowledgement at the beginning of today's meeting. So that's great. Governance, this will be the highlight of the day, right? Oh. So disappointed. The board and our new president, Dr. Walker, wanted to reinvigorate the governance committee, and so I took on leadership for this recently, and we've had some activity that we've been working on, just to let you know where we are. We are a group of individuals who've been looking at this to try and reinvigorate the organization and move us into the future. And we've had a few activities we've been focusing on. This is the cadre of people who are working on the governance committee, and thank them for the time and effort they're putting in. The revitalization is about setting up the governance committee again, establishing membership. We've taken on some specific activities to work towards the visioning of the future. And so the specific pieces of this are looking at terms of reference, which can be an important thing to make sure that everybody's pulling in the right direction. and that we've covered the various important aspects of governance, including EDI. As part of that, we're looking at all the terms of reference and how we're structuring. A bigger part of that is moving towards a strategic planning exercise. So this is the first time that PSI has done this in its over 50-year history. And it's been taken by the board to help make sure that we're pulling in the same direction and that we're optimizing our approach to the future of supporting research in Ontario. And so we've taken on this. We put out an RFP and invited some proposals a few months ago. And we got some good responses, some good proposals submitted. We shortlisted a few and interviewed those candidates. And I'm happy to say that we've contracted with an organization called Overlap just recently. And so we will be starting that strategic planning exercise. To say that this will lead to a report, so next year I'll be able to come with a report from that exercise, and it will focus on a couple of things. One is around the plan for how we manage our research granting activities and look for opportunities and even new opportunities where we might expand that and optimize that. And the other is looking at our governance and how we manage the organization so that we can move those things in the right direction. So those are what's coming up for the next year. Thank you.
Let me just ask if anyone has any questions for Ms. Bodkin or Dr. Devereaux. Okay. So that was just a little snippet to give you a sense of some new things we're doing. The Governance Committee isn't a new committee. It's been in existence forever, but it had not been active. So we're very appreciative of Dr. Devereaux's leadership in reactivating the committee to provide us with a plan going forward. And the EDI committee is a new committee, and it's really very much Giselle's interest and persuasion in this area that has generated this new committee. I think those of you who are involved in research will be well aware that other granting agencies have varying but quite stringent requirements around EDI within proposals, for example. CIHR, New Frontiers in Research, and so on, all have clear guidelines. So we're not exactly moving ahead before anyone else has, but certainly it's time for PSI to seriously ensure that it is a completely inclusive and diverse environment, both within the organization but also in everything we do that is externally facing. So very much appreciate your leadership, Giselle and John. So we are now going to give you a chance for a little break, and then we're going to come back to Dr. Deborah Cook, whom I will introduce. If we can have you all back in the room by 11:10, that would be very much appreciated. Dr. Cook's presentation, I know, is going to be a very interesting and exciting one. So thank you, everyone.